My name is Nicole Douglas, and I am so excited to be here with you to share our new solution, IMO Core cSmart. Before we get started, a few logistics things. This webinar is being recorded and will be made available for future viewing. All attendees are in listen-only mode throughout this presentation, but please use the question section in your GoToWebinar console so you can add in questions or comments there. We're going to have plenty of time to go through any questions here at the end. So in this webinar today, Dr. Deepak Pillai and David Arco will show you a new in-workflow approach to documentation and problems management within Cerner Millennium. And if you're joining today, chances are you probably know a little something about who IMO is. And we're so proud to provide the clinical terminology foundation that the majority of Cerner clients use to power their diagnosis search while connecting to the right regulatory codes behind the scenes. Our expert staff manages millions of terms each year and updates them silently to make sure that you have the most up-to-date terminology and mapping to support that rich documentation and also seamless billing workflows. So while you may know us as your clinical terminology vendor, what you may not know is that IMO is so much more than that. We like to think of ourselves as a healthcare data enablement company. And after being in the space for almost 3 decades, we know that data quality starts at the point of care. Our industry-leading point-of-care workflow solutions help clinicians easily capture coding at the point of care and also makes problems more meaningful. This expertise extends into data quality solutions that help structure and normalize that data for well-informed insights. Our footprint spans from healthcare provider organizations to global EHR providers to health information exchanges and healthcare analytics vendors. We're kind of all over the place. So before we get started into the meat of our presentation, we want to do a quick poll question. Our solution is a Smart on Fire app, validated through Cerner's code program. So in short, that means that our solution integrates directly with your Millennium instance with appropriate security guarantees. So in speaking with our clients, we hear that their experience with fire varies. So we're curious, how well has your organization implemented Smart on Fire solutions? We'll give it just a moment to populate here. All right, excellent. Looks like we're split between well and very well. That's some great news. And for now, I will pass it over to David, our product manager, to speak to you more about what we hear from the client.
Sure. Thanks, Nicole. So as we speak with our clients, not just in Cerner, but with all EHRs, we consistently hear 3 main themes about their challenges in the problem and diagnosis space. The first being that ICD-10 coding at the point of care is insufficiently specific or complete, which leads to low Medicare Advantage risk scores, denied claims, and other rev cycle inefficiencies. Limited native functionality makes problem lists cumbersome. As a result, they're often ignored and neglected, leading to an accumulation of out-of-date or redundant data, further degrading their value as a clinical tool. And then here's the real upshot of all of that. These patient data, they're the lifeblood of your EHR. They drive your reimbursement, your decision support, your quality reporting, your population health, your operational efficiency. If this underlying data is inaccurate, you're going to be hard-pressed to realize the promise of your EHR investment. So, another poll. Which of these challenges are you experiencing at your organization?
All right, looks like we're split here between improving risk scores and simplifying clinical EHR workflows.
Great, we can help with those. So our goal here at IMO is simple. We want to simplify documentation, i.e. your ICD-10 coding, and make your problem list more meaningful to support the best patient care. So our answer to these challenges is the IMO Core cSmart app, which is, as Nicole shared earlier, a Smart on Fire application that we built in collaboration with and had validated by Cerner's code program that offers powerful tools at the point of care for better ICD-10 coding and for more meaningful problem lists, which will result in improved rev cycle efficiency, more accurate patient data, and an improved physician experience. So how do we do that? Well, the first step to creating quality patient data is documenting problems and diagnoses meaningfully. IMO's precise problem terminology, which you may know as problem IT, allows you to document with the specificity required for appropriate reimbursement and the rich clinical detail ideal for quality problem lists. The next step is making problem lists more accessible. We do so by organizing the problem list into intuitive clinical categories to facilitate efficient review and recall and identify unnecessary problems for streamlined removal. And then beyond making the problem list meaningful and accessible, cSmart can make it useful by alerting the provider to unaddressed HCCs that may impact that patient's RAF score. And then crucially, cSmart does all of this while shouldering the maintenance burden for your clinical and technical resources, providing silent updates to ensure the app stays up to date across regulatory releases from SNOMED and ICD. But we really prefer to show rather than tell, so I'm going to hand the mic to Dr. Deepak Pillai, and he's going to provide a demo of the cSmart solution. Deepak?
Great, thank you, David. And hello, everyone. Thank you for joining our webinar. You can see, my name is Deepak Pillai. I'm a physician informaticist here at Intelligent Medical Objects. And as you can see on the screen, the app that we're talking about that Nicole introduced and David talked about some of the key features is what you're looking at in the main section of this test patient in this test instance of Millennium. Now, as I was listening to the poll questions, the responses to the poll questions come in, I'll highlight a very high-level overview of the solution. But I think what you'll see to your responses is how we can improve workflow, and particularly, as David mentioned towards the end of his comment, particularly around identifying HCCs and improving risk score participation in those programs. Okay, so by way of demo here, I'm going to close out the sidebars. It is important, though, to know that this is not a separate tool or widget, right? It's embedded, as you can see, embedded right in the mPages workflow as well. We can also embed a link here in the left navigation menu, as you all would deem appropriate for your individual workflow. But we find, because it's primarily a provider-based workflow, that it's most commonly incorporated into the mPage workflow. We could do both. For the purpose of the demo, I'm going to close out the sidebar so we can look at our app here in maximum view. First of all, out of the gate, you'll notice all of these conditions on the left. This is analogous to the chronic problems, to use Cerner vernacular. But you'll notice out of the gate, everything is organized automatically into their clinically intuitive categories, right? So now, in 2 seconds, you can know exactly what's going on with this patient from a cardiac and vasculature perspective. No longer do your providers have to hunt and peck through the entire problem list to identify the one or two crucial things. These are organized into categories that make sense to clinical workflow. I'll talk more about problem list management in terms of simplifying the workflow in just a moment. But first of all, a few quick things just to orient you to how to document with confidence and ease. There's some functionality at a foundational level that's on par with what's available in Millennium. So as we add on features, what we don't want to do in industry is to lose core functionality, so have functional parity, if you will. So with a single click, you can move conditions from a chronic list to today's visit, or this visit, as is commonly used in Cerner vernacular. And you can see conditions that are added to this visit. You can add new conditions directly from a nice search. So what you'll find is the search experience is far enhanced for providers. So you can search for common shorthand. So if I want to add hyperparathyroidism, I can just search for acronyms, clinical abbreviations, and so forth. This example in particular is a chronic condition. I not only am going to address it on today's encounter, but I know that myself or my colleagues will be addressing it in the future. I want to also add it to the chronic problem list. So with a single click, again, another example of some functional parity, I can add it to today's encounter and add it to the chronic problem list as well. This time, though, you'll see that it automatically gets added to the endocrine category. Another example of improving ease of workflow and helping providers process a problem list with what I like to call a lower cognitive load. Now, let's add some more complexity to these conditions so you can see these features play out as we go along. Say I'm seeing this patient from an ambulatory perspective after they've been discharged from the hospital from an acute stroke. So I'm seeing the patient for the first time in my office. I want to document on their stroke. You can see I can search by simple acronyms. I get nice hits that are tailored to my search criteria. And what I really want to show off here is you notice how some conditions have a plus icon and some conditions here have a calculator icon. The plus means that that condition is fully specified for ICD requirements. The calculator, on the other hand, means that that condition, in this case, the word stroke, needs more specificity for ICD requirements. So the option that we provide is a calculator icon. The providers click on there, and all they have to do is go through the decision tree that they already know of based on this patient's clinical condition. So it's an embolic stroke. Let's just say it's for the right MCA distribution. So now I've gone from a non-specific term called stroke that would have resulted in a .9 code and a denied claim to a highly specific condition that's appropriate for ICD. So not only does it improve workflow, but as those of you that mentioned that participating in risk-based reimbursement, the first step in that really is getting specificity. And you can see that the right level of specificity can improve your coding in and of itself. We'll talk about a risk-based, how we can help with HCCs, for example, in just a moment. But specificity is the first step to participating in risk-based reimbursement. Okay, and by the way, you saw those what we call modifiers for stroke. If I take a completely different example, I'm just going to pick gout, for example. You'll see that the conditions that come up with gout, the calculator icon, for example, is highly specific for just that condition. Notice these choices are unrelated to stroke, right? They're tailored for gout. We have hundreds of thousands of these terms that have content that's highly specific. All of our content is tailored for the search string. So in this case, I go from gout to acute idiopathic gout of the right toe, and now I have a highly specific term. By the way, what I advise to docs is search with the specificity that you already know of in your head. So after I've already assessed this patient, I know that it's on their toe. I might even have lab results back. And so I can search for what I already know. Pick gout of the right toe. Now you can see I have a highly specific condition, acute idiopathic, chronic idiopathic, other examples of that, and so forth. Or I can click the calculator icon for the search string that I search with, and notice that I'm only given the choices that I didn't already specify. Another example of how our content is highly tailored for the search string. And by the way, look what happens to the presence of tophus. When I choose acute, all those other choices go away. Our content is tailored to guide providers down with as little as down that path of specificity with as little clicks as necessary. Okay, so those are just a few examples. Let me take a very complex example, yet unfortunately is very common, which is diabetes. And in fact, you can see that on this patient's chronic problem list. I didn't have to search the whole problem list. I know exactly that it's in the endocrine section, and there it is. I want to address it on today's encounter. I simply click the one icon that says move to diagnosis because I think that's clinically appropriate, and then look what happens when I do that. I'm presented with a screen that reminds me that I need more specificity for a billable ICD code. So, and I'm guided down this decision tree. Say that this patient has long-term use of insulin. I don't know who's on the call, but for the clinicians that are on the phone, as you may be aware, there's a myriad of end organ complications that can occur, be they renal, ophthalmic, neurologic, et cetera, et cetera. Watch what happens when I pick any one of these. Say I pick kidney disease. All the subsequent choices are cleaned up, and I'm only presented with the choices that a provider wants, that are related to my previous choices that I chose as a provider. So I pick renal, chronic conditions, say on dialysis, and now I've gone from what I thought was clinically appropriate and perhaps does make sense for a chronic problem list to a highly specific condition that's appropriate for a diagnosis list that's used for billing purposes. Type 2 diabetes with renal disease on dialysis and insulin use. Now, when I add this condition to today's encounter, like we have thousands of these conditions that simply cannot be captured by a single ICD code, we will now automatically add all of the secondary codes that come with that particular condition. And you'll see those conditions added here. Forgive me if there's a little bit of a delay. It's related to my home office setup here, if you will. But you can see that diabetes code with the appropriate E11, that diabetes term with the appropriate E11 code, the code that comes with end-stage renal disease, and in this case, the lifestyle codes that come with being on dialysis and insulin use. You now have in one spot the right level of billing, the right level of documentation to support the right level of billing. And as you saw from the previous examples of the stroke, the gout, we have essentially eliminated the ability to unintentionally add unspecified codes or conditions. Of course, in many clinical scenarios, a diagnosis, the specificity of a diagnosis may not be known. If you go back to that stroke example, take an inpatient or an ER setting, that level of specificity may be unknown, and we provide appropriate exit ramps. So if I choose stroke unspecified, it is, often as clinicians, we're often constantly reminded that you cannot have unspecified conditions, but sometimes the clinical scenario warrants that. So really what we want to avoid is the unintentional addition of unspecified code. So when it's intentional and it's appropriate for that scenario, as you can see, we provide those exit ramps, then you would clean up all the subsequent choices. So it's another example of how we can help providers document with confidence and ease. Very quickly, we have historical diagnoses also. That is simply a running list of all conditions that were diagnosed and when they were addressed on what encounters. What I like from a workflow perspective is those clinical categories can be activated here. So now I can see when this patient's hypertension was addressed and in prior visits, regardless of how I called it. I may have called it primary hypertension today. My partner may have called it essential hypertension in the past. If it means clinically the same thing, we can organize them and present them to the provider in a meaningful way to improve their workflow and management of problems. All right, folks, there'll be plenty of time for Q&A at the end, so I'll go ahead and move forward with some of the other key elements I want to show you. From a problem list management perspective, we've already talked about these clinical categories. We can go even further, right? Organizing information is one step, perhaps the first step to keeping things clean, but we can go even further. We can actually proactively tell providers where those cleanup opportunities exist. And we do that on this tab. We call it the problem list cleanup tab. And we can organize information, all those chronic conditions that have expired in time, all those conditions that are exact duplicates of each other. So for example, this patient's problem list has 2 different ways to say ALS, 2 different ways to say CHF. And what I like clinically are those conditions, these what we call related groups, those conditions that are not exact duplicates of each other, but are clinically related and perhaps don't all need to go on the problem list at the same time. This, we see this example commonly, disease progression through various stages. And we have example of renal disease. Every time the patient presented, the provider thought they were doing the right thing by adding that condition to the chronic list. But what they should have been doing is deleting the old one, adding the new one, but nobody does that. It's because it's a disjointed workflow. And that's an issue across the board, right? This is not a Cerner issue. This is a problem with electronic documentation, is that managing a problem list can be challenging without the right tools. So when there is clutter, we can catch that and present it to the provider and say, hey, here are the cleanup opportunities. Now, when you go to clean up this problem list, it becomes much easier now to recognize, okay, that appendicitis is expired. I'm going to resolve that condition. I'm going to clean up the CHF. I don't need both of these conditions. You can see the problem list on the left automatically getting cleaned up in real time. With that renal disease, I probably just need the most severe condition, which happens to be an HCC. We present that information from a risk-based reimbursement perspective. We're not telling providers what to do, of course, but we're presenting clinicians with the right information so they can make an informed decision. Here's asthma is a great example, right? We have asthma and then asthma in the context of obstructive disease, the latter being an HCC. It becomes much easier now for the provider to know which one to clean up off of the chronic list on the left. So that's how we can help document with confidence and ease and help with problem list management in terms of keeping them clean and improving a provider's workflow. The last thing I'd like to touch on, especially since you all highlighted that your participation in risk-based reimbursement is so important, is how we manage HCCs. Now, Millennium does a nice job in calling out what conditions are HCCs. If you're aware, these are, I believe, highlighted in bold and red color on the chronic problem list. And what's also nice in Millennium is that when you search for conditions, and we can do that here as well, is that search results that are HCCs are called out as well in the search windows. But with this app, we can go even further. Number one, as you can see by the color coding, we can identify those HCCs that need to be addressed this calendar year. So amber means, hey, watch out, warning, pay attention to this one because it needs to be addressed. Whereas blue kind of means, I like to think of it as, hey, you can cool off. This condition has already been addressed this year, or a superseding HCC takes priority from a risk-based reimbursement perspective. So we can guide providers down the workflow right here on the chronic problem list, or in the search window, or in the cleanup tab, wherever they are, as to which HCCs to focus on. But we can go even further. No matter where they are in all these different areas, if they're an HCC, we can filter for just those HCCs and put them on a separate tab. We've had great feedback that primary care providers particularly like this feature because you can see what conditions are HCCs, and we don't just dump them on this list, by the way. We organize them. First, by those conditions that need to be addressed, we highlight those in orange, and we drop all of those that have already been addressed this year in the grayed out section, drop them to the bottom. Furthermore, we organize these conditions into clinically intuitive categories. In particular, those categories that are dictated to us by CMS. Take a look at, this is why this is important, by the way. Take a look at that CMS category number 85. This patient has 2 conditions that fall into that category. Watch what happens when I document on this patient's pulmonary hypertension today. When I move it to today's encounter, that entire category, all the CHF and anything else that happens to be in that category gets removed from the highlighted section and gets dropped to the bottom in the grayed out section. Because, as some of you may be aware, CMS is only going to reimburse at a risk-based premium, at least, for one condition per category. It is incorrect. It would be erroneous to continue to prompt the provider to document on that CHF for the rest of this year if that does not result in any additional premium. So we only want to guide providers down the right path where there's an incremental value. I think I scrolled over something here. Oh yeah, here you go. Take a look at this depression, by the way. This patient has depression on the chronic problem list. But back in January, there was an episodic occurrence that was addressed. There is no way, if I'm looking at this patient's chart on today's encounter, there is no way without a whole bunch of clicks and looking through various prior encounters or provider notes or what have you to know this was already addressed. So what we don't want to do is highlight that this depression is just because it's an HCC that I need to document on this here, because it would result in no additional value. So this is an example of how that workflow to A, improve workflow, as you highlighted was important, and B, to help you focus on those HCCs that matter. And finally, take a look at that pneumonia hierarchy. Notice here there are two categories of CMS HCCs that fall within the hierarchy of pneumonia. Watch what happens when I address this patient's aspiration pneumonia. Oh, by the way, this is a great example. I forgot to mention that it was what the etiology was. And so when I add it to today's encounter, I'm reminded that additional specificity is needed for a billable ICD code. So let's just say it's due to emesis of the right lung. Right. This is ICD requirement. So we guide the provider down the right path so they don't do what I almost did, was unintentionally add unspecified condition. So going back to my main point, look at that pneumonia hierarchy. We dropped the entire hierarchy, not just the conditions that are part of that category, but any condition that was underneath it, because as you know, not only does CMS pay at a premium for only one condition per category, they're only going to do that once per hierarchy. So another way in which we guide providers to focus only on those HCCs where there's value to be captured. So folks, thank you for your time. I hope I've been able to demonstrate for you at a very high level how to document with confidence and ease, how to improve problemless management, as David mentioned, and how to extract value around risk-based reimbursement for HCCs. On that note, I'd like to turn it back over to my colleague to close out our discussion, and then we can have some Q&A time to field any questions. David?
Thanks, Deepak. All right. So now that you've seen what cSmart can do for you, let's talk briefly about what this could mean for your organization. In reducing clinician HIT burden, i.e. improving your provider's EHR experience, our categorized view of the problem list, which we have live in over 300 sites now in various EHR partners, we have seen that the categorized view of the problem list demonstrated a 300% increase in adoption during a pre-go-live pilot, where the active users increased from 50 to over 150 providers just through word of mouth alone. And further, once this categorized view was made the default across the entire organization, 99.8% of providers retained it as their primary view. And this led to better clinical data. After go live, that same organization saw a 163% increase in problem list cleanup activities, which is intuitive that you group up similar problems and the providers are likely to take care of those redundancies. We also saw a 37% decrease in new duplicative problems being added. So think of those categories as a way to sort of inoculate your problem list against further clutter accumulating on them. And of course, we can help you get paid appropriately for the care that you're already providing. IMO's ICD-10 coding tools have demonstrated a 10% decrease in denied claims and a 24% increase in Medicare Advantage risk scores through better specificity and capture of secondary codes and better identification of persistent HCCs on that patient's chart. So we hope you saw a few ways IMO Core can help improve workflows around problems and diagnoses with the cSmart app. But IMO can provide additional terminology solutions to optimize your surgery scheduling system or your procedure terminology more generally. We also offer IMO Precision Normalize, which can help standardize and clean up your organization's data across all domains. And with this clean, standardized data, IMO's precision sets can help form the foundation of your analytics, offering clinically validated value sets based on IMO's best-in-class terminology. If you'd like additional information on any of these solutions, or would like to schedule an in-depth discussion of our cSmart app for others in your organization, please go to imohealth.com to schedule a demo. We thank you for joining us this afternoon and invite you to stick around for a brief Q&A session with our panelists.
Thank you both. We did have a few questions come in. I'll put out another call for questions. You can use the chat box in the GoToWebinar console. The first question, Dr. Pillai, I'll send this one to you. How does this work with my existing problem?
Great question. You know, to be to be transparent, and perhaps you've been able to pick up on this. Really, what we're doing with this tool is reading and writing to the existing problem list tables and diagnosis tables that already exist in your Millennium instance. So it's another way, it's a way that we think is user-friendly, provides the right information, and is integrated into the workflow for providers to easily interact with that table. But the downstream benefit of that is that any changes that are done through here will reflect in any other problem list tables that are buried throughout, any other usage of the problem list that is buried throughout the Millennium workflow, be it order entry, the left navigation menu, nursing or non-provider workflow, and so forth. And any changes made there are reflected here as well. So essentially, it's one of the same, a better way to interact.
Okay. The next question that came in is, how can I set diagnosis priority using your app?
Sure, I'll take that. The short answer is it's done automatically. Any condition that you add, forgive me, in the interest of efficiency, I won't switch screens yet. But if you remember from the demo, when I was adding to this visit, every time you add a condition, it will automatically be assigned the next available priority. Now, switching priorities and changing things around is more of a native Millennium functionality, but in many workflows, primarily in the ambulatory space, for example, you would never necessarily need to do that. So it gets automatically assigned.
Thank you. Next question, David, I'll send this one to you. What Cerner product is your solution compatible with?
Sure. Our app is compatible with Millennium versions 2015 and above. There are also some packages that you may need if you haven't implemented a Smart on Fire app previously. That will need to be enabled by Cerner. But 2015 and beyond is kind of the baseline. We have integrations in PowerChart today. We understand that it's also compatible with FirstNet, although we don't have implementations there, full transparency, but understand that that is a possibility.
Thank you. All right, that looks like all of the questions that came in. So thank you both for your time. Thank you for everyone for joining. We're happy to answer any questions that you may have. Just visit us at imohealth.com to schedule a demo. Thank you all. Have a great rest of your day.
Thank you.